I'll be discussing on this topic the early diagnostic dilemmas and challenges. A very common condition, unidirectional horizontal spontaneous nystagmus in acute vertigo beyond the acute vestibular neuritis. Coming on to cases straightway, the case one is a 56-year-old hypertensive with acute vertigo and vomiting for 1 day, no other medical comorbidities. Neuroocular motor and vestibular examination, unidirectional right beating nystagmus, head impulse test positive to the left, skewed deviation absent, able to walk self and no gait or appendicular ataxia, no previous history of vertigo or headaches. This is the head impulse test which I did at normal speed as well as the speed reduced to 30%. You see a right beating nystagmus and on head thrust to left there is a catch-up second over and above the nystagmus. However, this needs to be demonstrated by slowing the clip speed by 50%, which I have done here. And there you see the catch-up second. So the diagnosis is very clear: acute unilateral vestibulopathy of the left side and treated with steroids. And that's what we used to call acute vestibular neuritis. Case to a 40-year-old male patient presented with 10-day history of positionally triggered vertigo that started when the patient was supine and transitioned to lateral recumbency to either sides, severe vomiting initially. Since then, he continues to be symptomatic, but with some relief intermittently. Some days would be good, some would be very bad. No significant past medical or surgical history. The initial bow and lean test, the first 10 seconds of this video is the neutral position. I have not leaned the head. And you can see that there is no nystagmus. And then after I do a leaning here, still there is no nystagmus. However, after 30 seconds, there is a right beating horizontal nystagmus that you see right now appearing on your screen. Very clear. So on bowing the neck, the nystagmus direction remains same. The supine roll test was done. The sit to supine, you see a spontaneous right beating nystagmus. Fast forwarding it on right as well as left lateral head roll. The nystagmus remains horizontal direction faced right beating, and so also to the head here to the right. Here the intensity slightly increases, but it is direction fixed right beating. Head impulse test was done, a clinical head impulse test, negative on head thrust to right as well as left, repeated multiple times. This can sometimes occur in inferior vestibular neuritis, but this patient had a clear-cut history of positionally triggered disease spells off and on for past 10 days. So definitely the clinical head impulse test is negative. The head shaking maneuver was done for the first time. Here I am doing it. Head anti-flex around 30 degrees. and the nystagmus, which is right beating and direction fixed, intensifies. And this is so true of a left hyperfunctioning labyrinth. But why the head impulse test is negative? This is a matter to be debated. Head checking maneuver was done again, this time without the video frenzies on, for full 1 minute. So fast forwarding it, everyone hopefully knows how to do a head shaking maneuver. And now you see 1 to 2 beats of right beating nystagmus even without fixation being removed. But after that, there is no nystagmus. And the head impulse test is still negative to the left. Supine roll retest was done after 4 hours. No nystagmus. Maintained the supine neutral position for full 1 minute. Had your to the right as well as left did not elicit any nystagmus. Patient completely asymptomatic and vertigo free, and he continues to remain vertigo free, and this is almost 4 months from as of now. Final diagnosis is left horizontal semicircular canal Canalith jam that probably developed during bow and lean test, because the first 10 seconds of the bow and lean test did not elicit any nystagmus when the patient's head was in neutral position. Case number 3 is a 53-year-old male patient presents with 4-day history of spontaneous vertigo that started when the patient was upright, associated with multiple vomiting, light and sound intolerance present. He is a known case of migraine with migraine related dizziness MRD for past 2 decades, a diagnosis that was made when the criteria for vestibular migraine were not laid down. And he was taking topiramate 100 milligram twice daily for prophylaxis, almost self and self unsupervised for past 10 years. MRI brain done after 48 hours of the onset was normal. The gaze holding without removing fixation. Here you see absolutely no nystagmus on gaze to right. He is able to hold the gaze, as well as there is no nystagmus on gaze holding to the left. With fixation removed using mu Frenzel glasses from Lisbon, I could see a low SPV, low intensity, right beating horizontal nystagmus. So when you see a horizontal unidirectional nystagmus in any patient with acute vestibular syndrome, this has been the 4th day he was having. The next thing you do is to shake his head to look for its intensity. and here its intensity increases as faithfully occurs in all hyperfunctioning labyrinth left in this case. So next thing to be done was a clinical head impulse test. But before that, I repeated the head shaking because I was still considering this patient as a case of Canalith jam. Head shaking was repeated, and this time it was carried for a fairly long period. And there you see that there is initial disappearance of the nystagmus, and then it reappears the same low intensity, low SPV, right beating horizontal nystagmus. Looking like acute unilateral left vestibulopathy. But the head impulse test was repeated. The first time was also done, not shown here. It is negative on head thrust to right as well as to left. So, what to do? The patient was admitted. The episode had persisted for over 72 hours and had not responded to oral medication. So, I admitted the patient for intravenous hydration. The healthcare providers where I admit, they gave parenteral prochlorperazine, valproate, and magnesium sulfate during the 24 hours period. Next day, he was examined again. No spontaneous nystagmus. This is after 24 hours of treatment. That low intensity right beating horizontal nystagmus has disappeared. At this time, patient was completely asymptomatic of his ongoing spontaneous vertigo that was present for past 72 hours. So next thing that came to my mind was to shake his head, and I was also surprised to see these findings. And there you see a left beating horizontal nystagmus that lasted for less than 5 to 7 seconds. And then the eyes became static once again without any nystagmus. So before treatment, there was a low SPV, low intensity right beating horizontal nystagmus that increased on head shake. And after successful treatment in the non-ictal period, the patient had a in head shaking nystagmus beating to the patient's lap, but no spontaneous nystagmus. Final diagnosis: vestibular status migrainosus. My last case is nystagmus in vestibular migraine. Few words: is highly variable, may be spontaneous, positional, or head shake induced. Direction can be horizontal, vertical, or torsional. Direction and intensity may change between the ictal and interictal phases. Variability reflects the central vestibular involvement, amplified peripheral asymmetry, or post attack recovery. Head shaking can unmask or modify the latent nystagmus via the velocity storage mechanisms. Researchers have documented reversal of nystagmus direction in vestibular migraine. Case 4 is a lady, 42-year-old, came with acute unsteadiness in the morning of 28 March 2025. Remember this date? Treated as posterior circulation stroke elsewhere based on the MRI report of infarct in the medulla, and I think rightly so. I would also have done the same. Consulted us for symptom worsening, now rotational vertigo for past 2 days, despite antiplatelets and statins. Neurooculomotor and vestibular examination is here. The head impulse test is negative, done multiple times, as you can see, to the right and to the left. Did not elicit any nystagmus. That is a clinical head impulse test. So when you find a negative head impulse test, it always go to a central vertigo. The test of skew was possibly positive, but this came only once during a. Here this goes up. This could be a skew positive or negative because it was not repeated again. Unidirectional gaze evoked nystagmus. Here the examiner is slightly making a mistake, that is me only, taking the eye to the right extreme gaze because this can result in endpoint nystagmus. However, there appears to be a right beating horizontal nystagmus, which is even seen on lateral gaze to the left, but significantly more pronounced in right lateral gaze. Here you see that. So the next thing that was done was to remove fixation. To right, it is right beating, it is spontaneous, and on left gaze it is still right beating but with decreased intensity following the Alexander's law. So it looks like a peripheral nystagmus. So what happens after the head shaking? That is more interesting. After high frequency head shake, there is a post head shake nystagmus which is left beating and horizontal. This was transient. So her first MRI done on 28 March is showing a reported infarct in right lateral medulla, and 4 weeks later the size of hyperintensity has significantly increased despite patient being on antiplatelets and statins. This is the 22nd April, that is the second MRI sagittal flare showing a increased hyperintensity that was also showing post contrast enhancement. Final diagnosis was brainstem demyelination, and she had oligoclonal bands positive. Possibly this was the first attack of the demyelination. So a small right medullary infarct can produce right beating horizontal spontaneous nystagmus and left beating post head shaking nystagmus. The mechanism is static vestibular tone imbalance resulting in spontaneous ipsilateral nystagmus, asymmetric velocity storage dysfunction causing contralateral head shaking nystagmus. This dissociation is hallmark of the central vestibular pathology, particularly involving the medullary vestibular nuclei and their cerebellar modulation. So medullary vestibular nuclear lesions, especially those involving the inferior and medial nuclei, commonly interrupt the inhibitory interneurons. They spare the primary excitatory efferents asymmetrically. This produces a relative disinhibition of ipsilateral vestibular nucleus. The result is that the fast phase beats towards the side of the lesion. So in the right medullary demyelination, right beating horizontal nystagmus, this differs from the peripheral vestibular loss where the nystagmus beats away from the lesion. So when a unilateral medullary lesion produces a predominantly horizontal spontaneous nystagmus, it mostly beats ipsilaterally and reflects a central vestibular tone imbalance, results from selective involvement of the vestibular nuclear inhibitory pathways. However, the directionality is not invariable and depends on specific vestibular subnuclei and cerebral connections involved. So my final diagnosis is brainstem demyelination. I finish my talk here. Thank you very much.